now we'll Hi, good evening to everyone. Thank you for joining me. I'm Dr. Philip McMillan, and I have been operating since early 2020, talking all about COVID-19. For those people who do know this, we are usually operating ahead of what the scientific consensus is, and it's no different today. We're talking about some scientific concepts that very few people actually know about. But I predict that in the next 2 to 3 years, everybody will be aware of what it is that we're focused on. Fundamentally, what we're trying to do is we are using the scientific community, those people who are in the know, who are willing to break boundaries to find solutions for so many people who are suffering across the world. Now, what we have today are 3 speakers. And the way how this will operate is that we have each speaker presenting for about 15 to 20 minutes. We'll then have a short question and answer session with them for about 10 minutes. We'll then move on to the next speaker, and we'll try and keep the time frames relatively tight. So that will be 3 speakers in all speaking about the principles and some of the science around clotting, microclotting, apheresis, and so on. And so you will hopefully by the end of this have a much fuller understanding of this. As always, we'd like to specially thank our sponsor for helping to put this together. And we will be in between at the beginning and the end, we'll be playing a small, short sponsorship video that will help to raise their profile and the work that they are doing in the background. So without further ado, one of our speakers I'll mention had a very short time frame, so he will only be able to come in, do his presentation and jump out. But we have 2 of the other speakers who will be with us, and I will introduce them here now, Markus and Bridget. And what I'll ask you to do for me, guys, before we start anything else, is that I will ask you both to just say where you're from and your topic, and then at the beginning of your presentation, we will then focus a bit more on fuller background for you. So starting probably Markus, if you could just say yourself, where you're from, and what you'll be talking about today.
Thank you, Philip. Nice to be on the show again. My name is Markus Klotz. I am from Austria. I predominantly have been working in Cyprus, but I'm now working with my new research out of Switzerland. And my area of expertise is extracorporeal treatments, apheresis, and multimodal combination therapy.
Excellent. And Bridget?
Yeah, my name is Professor Dr. Brigitte König. I'm located in Germany, in Magdeburg. I'm running a private laboratory with focusing now on the diagnostic of post-COVID, long COVID, infectious diseases in general, and mitochondrial testing.
Excellent, excellent. So thank you. And these guys are going to be with me at the end, and we will then have a discussion where we'll talk generally about all of the presentations and take questions if you have any at that point. So we look forward to you staying with us. This is going to be quite a lot of information, but as I said, staying ahead of the curve and helping us to understand what is happening. So before we start, a quick word from our sponsor, and then we'll go straight to our first speaker.
So when COVID started on day one, that is January 2020, I think around the 18th, we dropped everything. And ever since that day, we've been working 7 days a week, practically around the clock on finding solutions. Everybody on that slide you see there, to some degree, are working almost either on a weekly or daily basis, or even in direct collaborations, in research collaborations, in publications, in lab research. And so, each one there you can see has significantly contributed either to treatment or to development or understanding the disease and other discoveries. And so it's a great honor for me to be part of that and to be able to mediate between all these groups. I'm kind of like the coordinating a little bit between all these domain experts.
Thank you all, and thank you again to Molecusan, which is now actually available from, I think, last week in the United Kingdom and also in the USA as Medicinals 9. So let's get ready to have our first speaker in just a moment. Great. Markus, you want to go ahead and you just do a quick introduction of yourself, and we'll take it from there with regards to the presentation.
Thank you very much, Philip. So, as I said earlier, I've been founding a clinic. We're now in year number 4, and the clinic is called Apheresis Center, European Union in Cyprus, and it's focused on various apheresis technologies that we use for treating chronic illness. And in addition to that, we have actually come up with co-therapies. Now, as a monotherapy, apheresis is great, but we've seen that its strengths in chronic illness really comes out when we start combining it with treatments like hypothermia, nutraceuticals, etc. So my area of expertise over the last years, I have been, for example, helping Molecusan with making their protocol perfectly aligned with apheresis, hypothermia, and other treatments. So let's get right into it. The title subtractive versus modulating versus additive therapies is probably quite unusual. However, what do I mean with it? Now, subtractive, modulating, additive. Most clinicians, practitioners have hit the ceiling with additive treatments, medications, supplements, substances that they can give to the patient, especially in chronic illness. So you have a progress, but eventually you will hit the ceiling. Modulating therapies can also be additive therapies when you modulate the immune system, but they can also be tech-based, medtech. For example, a hypothermia device like the Heckel HT3000, where we bring up the temperature of the patient to fever range therapy. Now, my area that I love so much, subtractive treatments. What do I mean with subtractive treatments? Subtractive means removing certain substances. And here we're speaking about various forms of apheresis, removing those out of the bloodstream, specifically in the form of plasmapheresis from the plasma. Next slide, please, Philip. So, can you make it large? Yeah, brilliant. So, this is basically just my little story. In 2020, I was infected with COVID in the late 2020. I found out pretty quickly that I was not really recovering normally. After 8 weeks, I went online and I looked, what if you don't recover from COVID? And I found a little video of a friend now, Jess Medinger, who's a science journalist. And he said, if you have these symptoms, you might have long COVID. And I was like, oh, that's not good, because it said mysterious, not treatable, no cure. And I was only 40 and I was bedridden at the time. So I started because my own uncle is a doctor, and I started to be my own doctor and researcher, actually, because he told me you have to. There's no way classic medicine can help you at this time. So I hired 3 different doctors. I didn't tell them about each other. I built my own laboratory, and I went into the research the 1 to 3 hours that I had. I went on preprint servers. I read all of the basic new papers, and after a long time, I started then doing the first treatments. It looked like a long time for me, but actually the brain fog only made me work 2-3 hours a day. I was 23 hours bedridden, and also couldn't tolerate light or anything. I was severely disabled. I was in a wheelchair. So I started the Apheresis Association at almost the same time. The Apheresis Association is now called the Long COVID Apheresis Community. The volunteers turned it into a bit of a different idea than what I wanted to do. I wanted to have like a board with doctors, with scientists, etc. They turned it into a community project, which was not what I intended, but it's a beautiful little open medicine product and community now. So basically, I myself, with all the research that I did, I brought myself from the Bell scale 10. And for those who don't know what the Bell scale is, that's the ability scale. I made it from Bell scale 10 up to 40 with antivirals, hypothermia, nutraceuticals, etc. So from being able to walk a little bit around, I was then able to move a few hundred meters around the house, step into a plane, etc. That enabled me to fly to Germany to Dr. Beate Jäger, where I received HELP apheresis. And HELP apheresis for me really sealed the deal. Within several months, I got completely recovered. 4 months later, I did my first kite surfing exercise and was able to do sports again, had no more pain. I had a list of about 30, 40 symptoms, extreme chronic fatigue, joint and muscle pain, mast cell activation, brain fog. I was 24 hours in pain. I had insomnia and so on. The list was really long. And just 4 months later, with the help of the therapies that I had discovered, plus HELP apheresis, I was fully recovered. This led me to do a training and volunteer time at Dr. Beate Jäger's, where I learned everything about SOPs, risk assessment, administration pathways, how to run a clinic, because I'm not a doctor. So I opened the Apheresis Center in Cyprus, in Larnaca, in February 2022. And from there on, the journey continued. Unfortunately, a year later, my own mother contracted basically COVID. And before that, she already had post-vac syndrome from the vaccination. So she was completely disabled. But thanks God, knowing what we knew from my treatment, of which we still use 60% today, we could recover her completely. She's now the only person that I know that is better than before, because she also had Hashimoto's, which with the therapy completely disappeared. So now we're in year 4 in the Apheresis Center, and we've treated over 1,200 post-vac long COVID and chronic illness patients by now. And just this year, I have moved my research to Switzerland, Zurich. Next slide, please, Philip. So apheresis. Well, after 4 years, I know what apheresis is. But to be honest, when I the first time heard about it, I had no understanding of it, what it is. So I just Googled it today, and the definition of the Oxford Dictionary is surprisingly accurate. Medical, a technique by which a particular substance or component is removed from the blood, the main volume being returned to the body. Here's a little graphic of how the word came to life from Greek over several influences into late Latin, and then mid-16th century, it was apheresis. What it basically means is nothing else but separation or removal. So, next slide, please, Philip. Here we have different types of apheresis. Now, this might look a bit complicated in the beginning, but let's break it down. Site apheresis is basically every form of apheresis, extracorporeal treatment, no matter if we talk about the plasma or the full blood, where we actually collect different cells, erythrocytes, thrombocytes, leukocytes, etc. We also have whole blood apheresis. We will come to that a little bit later. The difference is we don't treat the plasma, the liquid part of the blood. We treat the whole blood. The one category that probably is quite interesting in whole blood apheresis is hemoperfusion. Then we have the huge category of plasmapheresis. Plasmapheresis is more than 50% of the world market at this moment. And the very interesting part of that is, for us, in chronic illness, chronic reverse, therapeutic plasmapheresis. You can see the arrow going down, and that arrow is picked up in the next slide, please. Here we are. This is all therapeutic plasmapheresis. This is where my home is. Now, what do we have? We have non-selective, semi-selective, selective, and highly selective forms of plasmapheresis. Plasmapheresis, a form of apheresis that only treats the plasma, the liquid part of the blood. So to do that first, in the first round, in the first cascade, we have to separate the big blood parts, small, the red blood cells and the platelets from the liquid part. The liquid part is this yellowish liquid that you see on top of a blood sample if you put it in a shell for a few minutes. Now, in non-selective, it's very simple. Ion exchange adsorption, active charcoal absorption, plasma exchange are also known as therapeutic plasma exchange. Plasma exchange these days, in this days and age with spike opacity, probably not a good idea to do it with donor plasma, better with albumin plasma, artificial. But again, quite a lot of side effects. So the plasma exchange, in our eyes, that's more in an ICU emergency situation. Semi-selective, cascaded filtration. What does it mean? A cascade is basically just one after the other, where we have several filters. One form of that is our beloved inospheresis, or as in England, some people call it inospheresis. It's a double cascaded filtration plus adsorption. This filter filters actually by charge, by molecule size, and by a tryptophan-like adsorption surface. In this category, we also have cryofiltration and immunoabsorption, which is semi-selective, but we prefer the selective immunoabsorption, as you can see in the next column. So enzyme adsorption, immunoabsorption, LDL apheresis, dextran sulfate adsorption are all selective therapeutic plasmapheresis forms. Immunoabsorption is predominantly used in Europe. In Asia, it has been actually replaced with other forms of plasmapheresis. And I think Europe is slowly moving away from immunoabsorption too, simply because the cost is extreme. And also we have realized that immunoabsorption is quite invasive and sometimes only gives us temporary results. Other forms of apheresis are, of course, especially with multimodal combination therapy, able to give us permanent results. Now, the last column, highly selective apheresis. HELP apheresis, which stands for heparin-induced extracorporeal LDL fibrinogen precipitation apheresis. And we're not actually talking about heparin, we're in reality talking about heparin sulfate, which is a slight variation of heparin. Next, please. So here I will show you one little example of HELP apheresis, which we just discussed. If you look at the machine on the right side, you will see that all of the tubing, all of the liquids, all of the filters, it's a multi-step process, is actually clinged onto the machine. So all of these lines are actually pushed into the pumps inside, and they're just one-use parts. To prime this machine, priming is the process of cleaning every little bit of the pipes, the bags, the filters, the clamps. It takes about 45 minutes. After that, we have a waste of a few liters that we use for cleaning, and the treatment can start. The treatment takes about 2.5 to 3 hours, depending on how much plasma we process. Now, HELP apheresis is precipitation apheresis, highly selective. Precipitation is actually a model where we solidify pathogens. In the first step, we're separating the big blood parts, right? White blood cells, red blood cells, blood platelets, and we park them in the machine with heparin. Then the plasma is processed. We're actually turning it into an acidic environment by reducing the pH value to 5.12, and we do that by pushing acetate inside. At the same time, we're actually also bringing in the heparin sulfate, and that does a beautiful thing. It irreversibly binds to pathogens, and they solidify as a precipitate. Why do they do that? Heparin has a beautiful thing, heparin sulfate. The electrons stay always positive, even in acidic environment, whereas protein-based pathogens, they will turn even more negative from their electron load, and you have irreversible binding. Now, if at that point we would give you back the plasma, the patient would die. Not a good idea. So we first have to bring back the pH value to a normal pH value, and we do that by a counter dialysis, and we're using actually bicarbonate for that. And at the same time, we're doing what we call an ultrafiltration with a heparin adsorber, where we filter out the excess heparin, 400,000 units, and on some of those heparin molecules, there's also still pathogens stuck on. After that, if we would give you back the plasma with the blood cells, it would be quite all right, but you would start freezing. So before the last step on the side of the machine, on the right side, you see that silver plate. That's where we heat up the plasma and then bring back the platelets, the red and the white blood cells with the plasma and give you back body temperatured, perfectly clean blood without chemokines, without cytokines, without spike protein, without viral RNA, without viral DNA, without other substances. Not 100%. Every treatment removes between, depending on the substance class, 15 to 65% of each substance class, which is the reason why we need several treatments. Next slide, please. So here you see the filters before. The white column, this is before we start the treatment. It's just been flushed with a 0.9% NaCl solution. The next is how my current filters look. I do 2 treatments a month because I do not tolerate statins. So I remove my excess cholesterol, which is quite high since I had COVID. And this is basically how a current filter of mine looks. You see on the bottom of the filter, this little white precipitate. In this case, this is only cholesterols, LDL, triglycerides, and if you have familiar cholesterol, LP small a. Now, the last filter. This is how our filter looks after long COVID treatment or after chronic treatment. To be honest, this is a very extreme one. Most of the time, the filter will be 5, 8, or 10 centimeters. What you see here is actually my first personal filter. This is a picture of my filter when I had long COVID. So, next slide, please. And this is a second example, inospheresis, double cascaded plasma filtration / adsorption apheresis. Very modern, very, very helpful for what we do. The difference with HELP apheresis, because they of course do overlap 40 to 60%. They also both reduce spike protein. They both take out toxins and pathogens. They both increase the microcirculation. Now, whereas HELP apheresis has a better efficiency in protein-based pathogens and does actually increase the microcirculation more, this is a form of apheresis that does target environmental toxins better than any other form of apheresis, that targets autoantibodies extremely well at around 45%. When we're looking at immunoabsorption, which is selective, then we only remove autoantibodies. For example, GPCR, G protein coupled receptor agonistic autoantibodies. This machine removes about 45%. Immunoabsorption started at 65%. Dr. Renata Linkisch, Dr. Beate Jäger, and me, we have observed that if you do immunoabsorption too intensive, too many cycles too quickly, you will actually trigger new autoantibodies building up faster than if we do it with inospheresis and we do it slowly. Also, inospheresis is an extremely broadband plasmapheresis because the filter, the size, the pore size is quite small. The filtration is doing filtration by charge of the molecule, by size of the molecule, and there's an adsorption surface that also then adsorbs autoantibodies. Next picture, please. This here is the so-called eluate. Now, in HELP apheresis, we have precipitation, solidified pathogens. I didn't show you the before and after because it's pretty clear. The before is just a clear bag, actually. The after, here, you see all the pathogens and toxins that we removed. Now, the inospheresis has 2 beautiful things. First of all, it doesn't have the problem that many plasmapheresis have, building up pressure in front of the filter and then pushing through certain molecules in the last third of the treatment. And we can also reversely flush the filter, basically reviving the filter every 20-30% down the road of the treatment, doing the same as we would do in 4 or 5 treatments. Next one, please. Multimodal combination therapy. Apheresis as a standalone therapy is efficient in many illnesses, and there's been hundreds of thousands of treatments done, and the science is very clear. We're speaking about cholesterol, we're speaking about lupus, we're speaking about autoimmune diseases, we're speaking about rheumatoid arthritis. Very clear. The science in long COVID and post-COVID is very new, though, and we're having very good anecdotal, very good clinical research. We're starting to have better studies, and we're doing huge register studies as we speak. But we still have work to do. Next slide, please. So, what are the elements of combination therapy? We have figured out very early on that as a standalone therapy, apheresis is great, but not good enough. And also, one form of apheresis is great, but very often not good enough. We're one of the only, if not the only, private clinic in the world. Yes, we are actually the only private clinic in the world. There is one more, Professor Bornstein, which is a research university clinic in Dresden, where we combine HELP apheresis with immunopheresis. And we did actually also have immunoabsorption. We have now stopped immunoabsorption because we have seen that immunopheresis is actually, for chronic illness, in almost 90% of the cases, not only more affordable, but also more beneficial and less invasive for the patient. We've actually touched HELP apheresis, we've touched immunopheresis. Immunoabsorption is a highly selective form of apheresis where we only focus on autoantibodies. What we figured out, number 2, hypothermia, whole body fever range therapy. When we start combining that therapy, and we're actually bringing the patient in this really nice device called Heckel HD3000 up to fever range temperature, 39.8 degrees. Then what we're doing is we're frying free the receptors from autoantibodies that are stuck on there, adrenergic receptors, for example. They stick 7 to 21 days on those receptors. They go back into the bloodstream. We actually immunomodulate the patient. We're bringing, if we say it very simple, the immune system of the patient into the highest gear. And we're also flattening out the spiral part of the spike protein from SARS-CoV so that the body can easier deal with it. If we then also add one more thing, nutraceutical therapy, xenomorphics and senolytics, and make sure that we have at certain moments the certain level of those in the bloodstream on days of apheresis, on days of hypothermia, we increase the efficiency even more, which is why we call apheresis, hypothermia, and nutraceutical therapy, and here we specifically use Molikusan, the trifecta. We have made a specific open medicine protocol that's free for everyone. Every physician can just get it from us, where we exactly tell physicians how to actually take those nutraceuticals when they're doing apheresis, when they're doing hypothermia, etc. Let's have a look at number 4 to number 8. These are co-therapies that actually also provide results for our patients. If somebody has mitochondrial problems or gut issues, peptide therapy with MOTSC can be a blessing. Or if somebody has other issues, we use peptides like thymosin alpha, TB500, PPC157. If we have people that after chronic illness became overweight, we're even tapping a little bit into GLP-1, GIP peptides. But of course, microdosed and with care, and always with the right supplements. IV, intravenous treatments, if you give certain supplements, vitamins, etc., instead of orally, intravenously, you always have 100% absorption rate. Some of our patients are so depleted that oral supplements and vitamins have zero effect on them anymore, especially when it comes to amino acids and other things. They really need them intravenously. Mast cell activation therapy, here, some of the interventions, H1 and H2 blockers, nanozeolites, colon hydrotherapy, and leaky gut IVs can do magic, but it has to be taken with care because some of these people also suffer from MCS, multi-chemical sensitivity, so you have to go really slow with them. And of course, also with hypothermia, you have to do it gradually because heat and mast cell activation is just not a very good duo. IVIG, SCIG, intravenous immune globulins and subcutaneous immune globulins are actually a blessing for all of those where the T-cell response is completely out of order and they need support of donated immunoglobulins. And the difference is subcutaneous has a slow onset, long-lasting, and is easier tolerated, whereas IVIG, 3 to 5 days consecutively, gives you fast results, but wanes off after 3-4 months usually. And of course, we're also using medication and supplement protocols to top it off. Ivermectin if we have people with POTS, and so on, if we have people with hypercoagulation, dual or triple anticoagulation sometimes. And of course, most of our patients are actually on a multi-month Molikusan protocol after to reduce the spike levels. So I think we've touched basically everything. 20 minutes is actually a good duration to give you a little overview. And with that, Philip, back to you.
Wonderful. Thank you very much, Markus. This is some heavyweight stuff that you're doing here. And so I now see why you are along this line, because you have experienced this personally and you have seen the benefit personally. Is that one of the primary reasons for the inspiration and the drive for what it is that you're doing here?
Philip, I think it's the sole reason, actually. I was on an interview with a very nice gentleman who's an influencer in Germany. And in these channels, people always try to create a hero story, right? And I stopped him very quickly in the interview and I said, there was nothing heroic about this. It's not heroic having to slide on a pillow to the toilet. It's not heroic not being able to take care of your little daughter because you're 23 hours bedridden and the kids can't even come to your bedroom. Nothing about that was heroic. The only heroic thing was my wife being my caregiver and my mother. They took turns 3 weeks, right? So yeah, definitely that was the inspiration.
So when we think about it practically, however, this is a complex procedure. And it's equivalent when we think about it and we look at what you do at the time frame, the 2.5 hours plus the time to change over the filter. This is almost like a dialysis system. So complex, integrated process. Is this only relevant at this time? Can you see this being relevant 10 years down the line?
Apheresis forms have always been relevant, extracorporeal treatments. Dialysis is an extracorporeal treatment, but it's, of course, very different flow rates, very different machinery, very different filters. And also the cost involved. These things got much cheaper because you need 2 dialyses a week. Those filters come in at very low costs nowadays. Apheresis filters are technically extremely sophisticated, and the whole apheresis industry is working with low numbers. So unfortunately, all of the supplies are very expensive. You also need almost a year of training in some of these apheresis forms, like help apheresis. The machine has around 700 error messages, not because it's a difficult machine, simply because it's an incredibly sophisticated process. Is it relevant today? Yes. Apheresis is used in so many illnesses, and the science is crystal clear in so many of them. However, in our area, therapeutic apheresis used for long COVID and post-vac, this is new. So we still have a lot of work to do. Will it be relevant in 10 years down the line? Well, I think most of the clinicians that I talk to in all of the summits and all the conferences, they have seen an increase that doesn't stop. I think I was very naive when I thought I'm going to do a project clinic. In 3 years, I have treated everyone that needs it, and I can go back to my old job. We can no longer accept patients until the end of November currently. So our waiting lists are now 1.5 months, and they're growing actually. So I think, unfortunately, it will stay relevant, yes.
So when we think about the reality and the complex multiple modules that can be used in intravenous therapy, peptide therapy and so on, how difficult is it to find the right approach for each patient? Because at the end of the day, it's, as I say sometimes in long COVID, everything works and nothing works, meaning that some people get benefit, another cohort of people don't seem to get benefit from doing the same thing. How do you think apheresis fits in that picture?
As a mono treatment, apheresis works probably for 60% of the population. And when I say works, I mean significant improvement, and I mean permanent results. But the moment that we combine apheresis and certain forms of apheresis, because don't forget, there's no such thing as one form of apheresis. We're talking about 40 different filters that we can use nowadays. And approximately 10, 12 of those will have a great effect in chronic illness. So yeah, that's basically that.
A lot of my audience are probably interested, and I can notice from the comments and so on, when we think about people who have had negative effects from the vaccine, when you look at your cohort, because not all of them, some of your long COVID people would also be vaccinated, and they may have had long COVID before and then gotten vaccinated. Is there any difference in terms of how they respond to therapy, or are they about the same as the long COVID cohort who were just infection?
So there seem to be 3 main drivers in long COVID and post-vac. One of them, spike protein persistence. Second, microclots, fibrin aggregates with amyloid proteins. And the third one, GPCR agonistic autoantibodies. Those are the 3 ones that we identified. Of course, there's individual cases where we have reactivations, Epstein-Barr, mono, CMV, etc. There's also cases where environmental toxins are involved, right? So generally, these main drivers, apheresis alone can do quite a lot, but we need to add in multimodality, meaning if we do not use other therapies in combination, most of these people have bad cards. How do we decide who gets which therapy? Well, we're using not only AI, but we're also using our clinical data. We're using a method that was developed by a university to improve our clinical experience. It's similar to doing a study, but we're doing it with clinical experience. And we're actually starting in Switzerland a quite fascinating AI-driven study, a register study, where we put every treatment, every diagnostic, every intervention, every value, and the biotracking data, 24 hours of the patients into an open medicine data that we then analyze with AI. And that AI then basically spits out, if I prompt, for example, for a 47-year-old man with those 12 symptoms, 5 of those he had since 2 years, 3 went down at that period. These are the 5 that are currently bothering him the most. What was the treatment plan that you have seen in your patient population working best? The AI will know that very exactly. And then, of course, the doctor has to check and say, is this information I can work with to design a treatment plan that matches as good as possible? Now, that's going to be reality actually already end of 2026 because we're working on it constantly. Yeah.
One of the questions that I'm thinking about here, because we're still having ongoing circulation of COVID, and so people are still getting infected. When you think about the use of apheresis, imagine you remove the autoantibodies, you remove the free-floating spike, and then 2 or 3 months later, the person has another infection. Do they then need to have further courses of apheresis to try and help to resolve that?
Very good question. And the answer is no, but there's a big but. And I was the one trying that first. And so when I first reinfected, I was, of course, in a kind of semi-panic mode. I didn't want to go back to the wheelchair, right? So the first thing I did was, after the acute infection was over, apheresis, right? However, it later on turned out that's not needed. So we looked at the FLCCC, which is now called Alternative Medical Alliance, or similar protocols. We then refined them together with Dr. Gustavo Aguirre and others. And we now have a little early treatment regime, which is basically antivirals, blood thinners, etc. There's one, a natural one, if you have flu symptoms. And there's one that's a little bit more heavy weight. So you shouldn't do it every 2 weeks because on your liver and kidney, it's probably not going to be that great if you have confirmed or suspected COVID. And I tried it myself in 2 reinfections. And the first time I tried it on day 5, and I didn't feel the symptoms hitting. And then after I was fine, I kind of knew, okay, the doctors have worked this one out quite well. So the answer is yes, you have to do apheresis if you forget to go into early treatment. And it has happened. And thanks God, it was people that were financially independent. They came in with a smile and say, yes, I know, I need to carry my early treatment package with me, but that's on me now. And they had to do another 2, 3. Yeah.
Excellent. So a final question here from a perspective of expanding this resource in different parts of the world. That's tremendous amount of investment, financial investment. How easy is it to get the support of investors, even from the start, to do this kind of work?
So in our clinic, the investors all had long COVID. And they were all very fine with losing their investment as a donation, worst case. For them, the outcome was good. After 4 years, we are now maintaining stability and we're covering costs. So that's great. Unexpected. And they all no longer have long COVID. So in our case, it really worked out very well. But why don't we see a lot of these clinics coming up? Well, there is a few coming up that have a part of the portfolio. First of all, large investment. Second of all, very hard to learn. Third of all, incredibly hard to run profitable, right? Why do you think HELP apheresis is no longer existing in the US? Hospitals stopped ordering those machines because they could not run them profitable. And unfortunately, in medicine, especially in the US, a lot of it is done because it's profit driven.
Excellent. That's great. So, well, we look forward to having further conversation on this in the roundtable. So, I'll ask you to wait with us, Markus, so we can discuss it. But we will straight away move on to our next speaker, and that's Yannick Koch, and we'll discuss his work and research. So, thank you again, Markus, as we move on to the next step.
My pleasure.
And now we're going to introduce our next speaker, Yannick Koch from Switzerland, who will be talking to us about microclots. So without further ado, Yannick, do you mind doing a quick introduction of yourself just before you do your presentation?
Thank you, Philip. Thank you for the invitation to speak at this online symposium. So yeah, I am Yannick. I'm the laboratory manager of IS Laboratories. I develop advanced imaging workflows that aim to provide a bridge between science and application. I'm a molecular cell biologist by training, and I first joined IS Laboratories leading the FibreScore project, what I will be talking about today. Currently, I'm the manager of the IS Laboratories, and I contribute to the broader pursuit of the IS Medical Group by establishing relief medicine as a defining force in modern healthcare.
Excellent, excellent. So without further ado, I'll let you get straight into your presentation. We'll try and keep it tight to about 20 minutes, and I will let you know when we're close. So you can go ahead, Yannick, and you have control of your screen.
Thank you very much. So yeah, I will be talking about fibrinolytic microclot complexes as a marker for chronic inflammatory diseases. So first of all, I want to state this is not a project I do alone. Here within the lab, I work together with Sylvia Peach. She operates the machine. Outside of the lab, we have advisors like Felix Schultman from the University of Zurich. Work together with Simon Abrahams from the University of Liverpool and Andrew Aswani, also from the UK. Having said that, we are the official licensee of the Biocode assay that I will be talking about, a spin-off company from the University of Stellenbosch, first developed by the group of research Apheresis. So for my presentation, it is important to know how are fibrinolytic microclot complexes formed. And this is your normal biology scheme, and I will go quickly through it. So what is important for my talk is that upon vascular trauma, clotting cascade is activated, or upon inflammatory molecules circulating in the bloodstream, there's the formation from fibrinogen, which is soluble, into the fibrin monomer or the fibrin polymer, which is insoluble. When we look at it in a more schematic way, you see that this fibrinogen, it forms together, and it forms these long structures, so kind of like spaghetti. And one can imagine that when you put too much spaghetti in a pot, spaghetti tends to clump together and form these clumps, and they're not really nice to eat. You have to pull them apart. And that's actually what is happening inside the body too. And if we look at these spaghettis under electron microscope, this is how it looks like. So you see this web of all these different fibers, and one can imagine that if you have some small fibers that are identified, the minor fibers here indicated by C, or the bigger fibers indicated by B. If you have too many of these fibers together, just like with the spaghetti, the size between the spaghettis, it is reducing. If we look at this in a more closer way, here you see these fibers coming together too much. And if they come together too much, there's too little space around it for enzymes to go there and to break it down. So these, as it was first termed dense depositions, they become hard to break down, and then they can become pathologic. So that is very short how they are formed. Now, where are they formed? So FMCs, as we call them now, in disease. So we see them in all these type of diseases, and what these diseases have in common is, first of all, FMC presence, but all these different diseases like diabetes, migraine, sepsis, and so forth, they have an inflammatory character. And could that be, that's what we hypothesize, be the seeding event for the formation of these FMCs? And it's not only our idea; these FMCs have been reported by in literature. So there are many articles on migraine, on diabetes, on ME, SFC, but also on COVID-19 infection and long COVID. As this is a long COVID focused symposium, I will talk a bit more about it. This was an interesting paper published in 2024 in Nature, where they show that fibrinogen interacts directly with the spike protein. So here on the left, you see a biochemical assay. What they did is they add fibrinogen and the spike protein in the same liquid, and then they see if they bind. And what they found here is that indeed, if you add fibrinogen and the spike protein together, you do find them bound together. Now, this is a biochemical assay. If you do this in human plasma, and then you look for the clot formation within the human plasma, you see here in red that when you add the spike protein, there is more clotting formation happening and quicker. If we then look again with an electron microscope, how does it look like? Here you have the control images, and here is plot with a spike protein added, and you can see these web-like structures forming again. So here is these spaghettis forming this structure again. In this paper in Nature, they really show in a quite cool model that it's indeed that it's fibrin that drives the lung pathology in the SARS-CoV-2 infection by this model. So there's a mice model with a fibrin knockout inside the lungs and a fibrin mutant. They injected these mice with the SARS-CoV-2 virus, and then looked at the lung pathologies. Now, what you can see here in green, it's macrophage infiltration, and you see that in the wild type, there's a lot of green, so there's a lot of infiltration. When the mice do not express fibrin, there's way less green, so there's less infiltration. I will not go into detail now on the specific mutant. If you look here in red, this is a marker for oxidative stress. You see that there's also more oxidative stress in these mice in the wild types compared to the knockout. This is a marker for the model because you knock out fibrin, you don't expect to see any red in this staining. And here in the H&E staining, it's collagen that is stained, and you can see that indeed in the wild type there's more collagen being deposited in the lung, so more stiffer lungs, so trouble breathing. I think this model nicely illustrates that it's indeed fibrin that drives the lung pathology in a SARS-CoV-2 infection. Well, how is this in humans, and what happens exactly in humans is this is the paper by the group of research Apheresis, and they use the method of what we are also using in the lab, which I will get into later. What they did is they had a control group, and they took the platelet pore plasma of this control group and of people, patients with long COVID, and then they looked at the microclots, or the fibrinolytic microclot complexes. And what they saw is that in patients with long COVID, they observed more of these microclots, so more objects, and the objects that they detected, they were on average, they were also bigger in the long COVID group. And this for us was the indication, hey, might this be something to identify control or healthy people from long COVID group? And that brings us now to our test, the Fibri score, where we try to translate invisible stress into visible markers. So what we use to do this, we use an imaging flow cytometer. Here's the image of from the company, from Cytec. Here's our imaging flow cytometer. And you can see it looks complicated. It's an amazing machine. So how it works is there's a flow cytometer. So you have a flow cell here where cells go through very quickly, and then they're being illuminated by different lasers. And here's a microscope setup. And the cool thing about it is that instead of taking one image and then analyzing this one image, going to the next place, you have a continuous streams of cells or whatever objects passing through your lens, and you can take images of it. The problem is when you think about if you want to photograph a moving object, you have it's hard to get them in focus. So to solve this issue, what the company came up with is time delay integration, and it goes as follows. So there's a cell passing here, it falls here on the CCD camera, and then later the image is reconstituted. Of this we make use of by analyzing our sample and in greater depth. So what we do is that we have a fluorescent dye, thioflavin T, that binds to amyloid-like structures, as has been shown, and we add the thioflavin T into the platelet-poor plasma where the microclots are. Then we put them through the imaging flow cytometer, bringing us to different images, so fluorescent images indicating THT stained particles, and a bright field image. We use the THT fluorescence to identify which of the particles are amyloid in nature, and the bright field then to get all our numerical values. So first, it is good to talk a little bit about what do we see under the flow cytometer. We see a lot of different shapes and sizes, and they're all microclots. As you can see here, we see more of these very tiny microclots, and we see less of the huge accumulations of microclots. Thought is, and this is a hypothesis, that these microclots, they are more pathological, as they are very big. They can block a capillary and then prevent blood flow going there, inducing hypoxic conditions. So what we did is we wanted to reproduce the data that was published by the team of Richard Apheresis. So what we did is that we took platelet-poor plasma of people that suffered from long COVID or long COVID induced by vaccinations, and then we compared it to a group of healthy people. We divided the different sizes of microclots into different groups: small, medium, large, and extra large microclots. And what we see is that there's a big difference in the small microclots, and also in the medium-sized and in the larger size and the very large size microclots. You see a little bit of that the differences aren't so big. Our thought here is that this is as we take the blood outside of the body, these big microclots, they might fall apart into the smaller microclots. Hence, the effect is less pronounced as in the medium and the small sized microclots. But still, it's good to know we do see a difference between the long COVID group and the healthy control group. So, based on this healthy control group, we have defined a reference range in what we expect to see when we measure microclots in patients, and we have defined that for every different subclass of microclots. Here is an example of our report. So here there's a patient. This patient is suffering from chronic inflammatory disease. I don't know exactly which one. And what we see is that we see a high number. So what this high number represents is we measure many events, and in the computer we add all these events together into one big microclot. So we don't take an average or a mean, we take a sum of all microclots that we have detected. So this we do for the total amount of microclots. Here I only show the small and the large and the extra large, but we do this for all the different parameters. And if you see this patient is suffering from chronic inflammatory disease. Indeed, there's a 3 times fold change the extra large microclots compared to the healthy control range. Well, this is a healthy subject. What we see here is that the total amount of microclots in millimeters square is not as high. It falls within the reference population. We see a slight bump in the small microclots. Microclot formation is a normal biological process, and every person is different. Some people, they have a little bit more microclots, or they're getting sick, or they were just sick, so they still have a bit in their system. But on average, overall, we see very little microclots in this healthy subject. We also make a graphical representation of this. So here in red, there is a depiction of the amount of microclots that is measured in this specific sample. And here in green, this is the reference range. In the dark green line, this is the mean, and the shaded green, this is the complete range. And you see for this person, the majority of the red line falls within the reference range. There's just a small peak of the smaller size microclots that we detected in this specific patient. Well, as it is a very visual assay, we take images for every and each patient. We also provide some representative images of what is actually taking place inside of your body. And we see, and the feedback that we get here is also, it is very nice for patients to see, okay, this is happening inside of my body. These huge microclots, they are detected. And one can imagine that if you are suffering from shortness of breath or brain fog, that these microclots, they may obstruct the capillaries, inducing these hypoxic conditions, local hypoxic conditions, that can be an answer to your to the symptoms that you have been feeling. So yeah, as I said, I work at IS Laboratories, but I'm part of the IS Medical Group. And the thing of the IS Medical Group is that we do apheresis. And specifically, we do inapheresis. And a big question for us is inapheresis able to filter out these microclots from a patient? We use the TKM58 filter in the inapheresis. And the filter, the pore size is in the nanometer range in this filter, and microclots, they are in the micrometer range. So from a physical, if you think of the physics, big particle, small hole doesn't fit. So what we expect, we hook up a patient with high microclots, and after apheresis, we should not detect these high microclots anymore. Then we got this data, and this was a surprise. So here in gray, you see the initial value before apheresis, and in red, you see the value directly after inapheresis, and we see an increase. And we got worried. We were surprised to see this. And we started to think, how can this be? Because if you think of the physics behind it, we should remove it. And after thinking a bit longer about this data, we thought, okay, maybe the sampling point is not the correct point directly after apheresis, because inapheresis is a process where you're hooked up to a machine. It is causing stress. Inapheresis gives the power back to the body to self-regulate, but this self-regulation doesn't start immediately after. And when we also looked at different parameters, so this is a beta amyloid protein levels in blood before and directly after apheresis, so it's taken from the same needle, we also see an increase in the amount of beta amyloid inside of the veins, inside of the blood. So what we then did is that we sampled not directly after, but a few days after the body has time to resettle again after the treatment. And what we then saw, and this made sense to us, this also coincides with a patient feeling better, maybe after inapheresis. Not the first minute directly wonderful, but after 2 days after having this self-regulating effect again, the patient feels better. And this goes hand in hand with the data that we now see. So this is 6 days after inapheresis, the first and the second analysis. And here we see a huge drop in the amount of microclots. And this patient also feels better. And when we look in another patient before inapheresis and then almost half a year after inapheresis, we still see this lasting effect of a reduced amount of microclots. I have to say, these are examples. We do not have the data of a big study. And this is something we are aiming to do, but right now we don't have the data yet. We are working on this. And hopefully in the near future, I can tell you more about it. So with that, I come to the end of my talk. Before I leave, I want to leave with a few key takeaways that the FMCs, they are formed in a variety of diseases, and these diseases, they are all inflammatory in nature. That our test, the Fibrin score, supports the monitoring of treatment effects, and that it is important to consider sampling time for Fibrin score inside of your pre-treatment protocol. I'm happy to develop that together with you. And with that, I come to the end of my talk. Here in the lab, I do not work alone. This is my team. If there are any questions, I'm happy to receive them, and you can contact them you can contact us on the following email address. Thank you.
Excellent. Wonderful. Thank you very much, Yannick. And for the sake of the audience, I'll be asking some questions now that I think are relevant. And I'll start off probably with what I found the most standout observation. You first have identified that microclots are real. And so for many people, I can tell that within the scientific community, there are a number of people who don't believe that this is necessarily much different from what it was before. It's just that because you're looking for it now, you're seeing it. Is that a fair thing to say?
I can understand it. I can understand this feeling. And the answering the question is, I do not have the definite answer for it because we didn't look before. We cannot make this comparison. What we do see is that there are people with microclots that do not suffer from any symptoms. But we see many more people that have symptoms that have high microclots. Therefore, I think it is a valid thing to look at. It is, of course, not as clear as with fever, where you can easily measure, this is high temperature, this is low temperature. Microclots, they've always been there. And right now, people with chronic inflammatory diseases, they're elevated. This is what the data tells us. But if they are now more or less than before, the definite answer I cannot give you.
So it raises a good point then. So microclotting occurs normally when people say are sick, or they're transitioning between disease, or some people with chronic illness will have more microclotting than somebody who doesn't. So is it more to do with the fact that the system after the pandemic and probably ongoing exposure to spike protein, that system that normally addresses it is being overwhelmed?
That is a good question. So microclots are not only formed on spike protein. So how I like to imagine it is there's how drops are formed in the air. There's a dust particle and water accumulates on it, and whether this dust particle is a spike protein or a different type of inflammatory molecule or some cell debris, this can be. This can vary. During the pandemic and after the pandemic, there's of course more spike protein present in humans than before the pandemic. Therefore, it might be correlated that that there's an increase in that this is due to the spike protein, but it's not solely due to spike protein presence. There are many other triggers or seeding events that can cause this accumulation of fibrinogen, forming these spaghetti-like structures. And when the spike protein.
And one of the things, as I said, my standout observation was when you brought up the chart showing what happened in terms of the amount of microclots immediately after you had done apheresis, and comparing it 6 days and about 6 months down the line. So the fact that the body takes some time to recalibrate, it does almost feel as though it's in an overwhelmed state, where when you reduce the burden the body can then get back to doing what it normally does because you've screened out much of the muck that's almost dirtying the river. Is that a good analogy?
It's a perfect analogy, actually. This is how we see apheresis. Apheresis is not the way of curing cancer and doing this and doing this. It is allowing the body to self-regulate again. So you filter out a lot of misfolded protein particles that can be this seeding event for the microclot formation, and giving this self-regulating capacity again, because your system is constantly overloaded. And you remove a little bit and your system can work again because it's not overloaded again. This is the general idea of the apheresis, how you describe it. I agree with it, yes.
And so I can only imagine, and I don't want to talk about costs at the conference, but this is not likely to be a cheap or simple procedure. When you think of the people who are most likely going to benefit, is it necessarily the people who have the worst symptoms, or is it the people who have the worst scores?
So sorry, that I understand your question correct. Is the question regarding to the fiber score, the measurement, or for apheresis?
Well, I'm just trying to think about it, because when you think about labs that can offer this, if you have a population of 30 million, and if you imagine 10% of the population have chronic symptoms, say for instance with an elevated score, but you can only address 0.1% of people who are struggling. I'm trying to understand, how can you know who is most likely going to benefit?
So, I struggle a little bit with understanding this question.
Oh, so I'm sorry. So I'm just thinking about all the people. I'm realizing that this is tremendously valuable, but you will have limited resources in terms of how many people can be treated. So I'm thinking now, oh my goodness, there are so many people who have this burden. How do we, and I'm thinking about this from a clinical point of view, how do we prioritize who would most benefit from this kind of intervention? That's really what I'm thinking about.
So I'm not a medical doctor. I'm a scientist. I'm only thinking about this. So the medical application is hard for me. If I go back to this fever option, I like fever analogy. Once you know you have fever, you know what to treat. But I have no idea how to treat. I'm interested in doing the measurement. And if you have 40 degrees of fever or 38, the difference might be. The difference in treatment modalities might be huge. This I don't know so well for long COVID. I know that we have patients with really that are on the far side of a spectrum, and people that are just borderline showing microclot, slightly elevated or very elevated. We do see that difference. In terms of treatments, I find it hard to say which person is going to benefit more. Is it the person with the huge amount of microclot? So I know personally from myself that I do not have a long COVID, but as an individual, I am on the higher end of the healthy population, and some other people that we have tested that are in the healthy range, they're on the lower range. So it's too early days to say, oh, this person is going to benefit more based on our score. What we do know is elevated or not elevated. The elevated people are likely going to benefit more than the people that do not have an elevated.
You just touched on something there that was a follow-up question, which is that when the public thinks about it, are they, even if they are feeling okay, not necessarily perfect, they're not having any major symptoms, would it be wise for them to see how much microclotting they are exposed to?
I think that is a very personal question to answer. No, some people prefer to know their genetic, if they have a genetic predisposition for certain diseases, so they can act on it. And for microclots, this might be the same. Some people prefer to not know. If you feel okay, why test? and some people want to test because of as a prevention measure. This is a personal thing. I cannot say you should do this or should do that.
And so they look at the whole system, because this is now becoming a much more significant concern, as we see, as you highlighted, spike protein does seem to trigger fibrin, which makes microclotting. We have ongoing circulation of virus, which people are getting infected by. Are we to presume that with every infection, we could see, if we were monitoring it, surges of microclotting?
I would hypothesize so, yes. And I would love to do the test. I would love to prove and test this hypothesis, but right now my assumption is yes. You would get surges.
And so when we think of the people who are struggling now, because you said certainly when you looked at the long COVID cohort and the post-vaccine symptoms cohort, they tend to have higher loads of microclotting than the healthy cohort.
Exactly.
Is there a difference between the two groups of the infection related versus the vaccine related, or are about the same? I don't know if you broke it down in the presentation.
No, I did not break it down, and we also did not break it down here in the lab. We put them all on one pile. This is also to have more statistical power, and this is all self-identified. There is not one test to first stratify these different groups. Or this is induced due to an infection, and this is induced by the vaccine. This is self-identification, and if we do these big studies, then we can start to separate. But right now, this is not 1,000 people. These groups are lower, therefore we add them all together, because the people, they suffer from similar symptoms, so it's more symptom based than what is the origin.
Excellent. And as we tying this up, and we're coming to the end of this, as we go forward and we think about the procedure of doing the apheresis, I'm assuming it's very similar to apheresis with regards to filtering out the microclotting. Is that a simple procedure? How long does that take somebody? Are they on a machine for an hour, 2 hours, 6 hours?
I'm not the expert on the treatment. I can only talk from a few hearsay, but it is approximately 2 to 3 hours on the machine for apheresis. For other treatment, I do not know.
Excellent. So this is, as I have predicted and anticipate, what we appreciate is that there are people in the scientific community looking to try and find ways to manage some of these unusual patterns that we're seeing after the pandemic. Now, when we, as a final question, when we look forward, looking at what this is, what would be your ideal circumstance? What would you want as a company that would help you to take this to the next level?
I would love to do this in a big setup with and add as many other biomarkers as possible to identify the correct one. Because as I said, stratifying these different groups is a huge challenge. This is very challenging. Long COVID is such a complex disease, and there's not one marker that we can use. So to do this in a grand setting with big groups with statistical power and different biomarkers, this would be ideal for me to do. Yeah.
Wonderful. Thank you very much, Yannick. I'm so sorry you won't be here for our roundtable discussion, because I think that we'd have had so many questions, but you had sadly have to leave a bit early. So thank you very much, Yannick. And I'll just say quick hello to you after we've let you out of the studio. And could everyone hold on for me as we Thank you for joining us back as we move on to our third and final speaker. which is Professor Bridget Koenig. I'll ask you, Bridget, to do a quick introduction of yourself again, and your background and what you're going to talk about, and then I will handle the slides for you. So you can go ahead.
Yes, hello together. My scientific background is chemistry, biology, and medicine, and I focused on medical microbiology, on microbiology in general, infectious diseases, infectious immunology, and especially of mitochondrial. Yes, that is my background. I think I have an own laboratory now at the MMD at Magdeburg, where I'm running a lot of tests and research.
Excellent. So I'll flip the slides here for you. Go ahead.
Yes, you already know that we are testing on spikes, and I will just show you some experience and some ideas whether we can improve our testing. The next slide. Just for remembering, we are talking about SARS-CoV-2, and SARS-CoV-2 has different proteins, nucleocapsid membrane proteins like other viruses, spike, and especially the spike protein. The spike protein is this one which is entering or communicating with the receptor on our own cells. It's especially the receptor is the angiotensin converting enzyme 2. And if it binds, or if the spike protein binds to this receptor, then there's activated some proteases, and then the virus can enter the host cell. That is a traditional procedure. A virus can't enter our host cell if is there not a receptor. The next slide, please. And the SARS-CoV-2 has one big feature is we need for our infectious defense, we need an intact immune system, and the immune system is dependent on our mitochondria, which not only give the energy like adenosine triphosphate, but also is involved in signaling, in antiviral signaling. If a virus or bacteria, and this SARS-CoV-2 wants to survive, it is a strategy to target the mitochondria so that the mitochondria is disrupted and it can't anymore defend in immune cells against the SARS-CoV-2. So the mitochondria are in the crossfire of infection immunity, but also in therapy. The next slide. So now we have a complex scenario. We know that the SARS-CoV-2 has the spike protein, which is a pathogenicity factor. But from my side, unfortunately, the SARS-CoV-2 spike protein is also involved in vaccination. So the spike protein can come from the infection as well from the vaccination, and has acute as well as post-acute syndromes, as well as in SARS-CoV-2 infection, as well as in vaccination. On the next slide, we see that it is still more complicated because we have often combinations. That means that most people which are vaccinated have also a COVID SARS-CoV-2 infection, either before or after vaccination. So we have a combination, and we have to decide what is the reason. And now we try to look what is the consequence, or can we have a biomarker of disease or of spike protein or SARS-CoV-2 vaccination-induced pathology. Sorry. So the next slide, please. And these are now a few publications which show that the spike protein, unfortunately, is remaining in our body. Here we have the spike protein of the SARS-CoV-2, of the virus, and it was detected in the brain very long after infection, and it contributes to neurological problems in the brain. The next publication shows you on the next slide that as well the spike proteins from the virus as well as from the vaccination show similar pathogenicity profile. So again, we have a complicated scenario. We have as well the SARS-CoV-2 spike protein as well as the vaccination induced spike protein. And at the moment, we can't distinguish from where is coming the problems. But nonetheless, we have problems from both sources. So next slide, please. I'm just summarizing some spots. Here's again that additionally, the spike protein is found in exosomes. What are exosomes? Exosomes are vesicles which are released from cells, from organs, from tissues, and which can circulate in our body. We don't know exactly whether these vesicles, or the exosomes, are put out or done out of our body as a garbage, or whether they circulate and infect again other tissues, because exosomes can have different tasks. On the next slide. The next slide, please. Okay. And here is again that the spike proteins in exosomes we already had, and especially the spike protein can also stay in monocytes. We know this from tuberculosis, that monocytes pick up every proteins which does not belong to our body. But in the case of SARS-CoV-2, there is some specific because there are a specific type of monocytes, the CD16 plus, are picking up the SARS-CoV-2 protein, and unfortunately, these monocytes are no longer active. They are in a senescent state, and that means that they are producing a lot of pro-inflammatory cytokines, and which is adding to a more problem of the disease. The next slide, please. So therefore, we looked what can we do, or where can we measure or analyze the spike proteins. And so we said, okay, it is useful to analyze the spike protein in plasma serum. Sorry, this is in German language, but I think you see the plasma serum, it's similar. We looked at the exosomes, and we looked at the immune cells to look where are the exosomes, and perhaps there are different strategies, different therapeutical approaches to remove the spike proteins. The next slide, please. And that are the first calculations. It is only from this year. It's not from the last year that we will do in future, but we just look on the quantitative distribution of spike proteins in plasma serum, and we divided it a little bit in female and in male. And just look on the left side, we see that negative in plasma serum, we have mostly negative results, only a few positive results, and we are thinking why. I think that is because in the plasma serum, we can't detect free-floating spike protein because the people have a lot of antibodies which capture the spike protein, so that we can't see any free-floating spike protein. The next slide, please. Sorry for the German. I was thinking that I have translated it, but it's the same. It's the quantitative distribution of spike proteins. Now it's in exosomes. On the left side, it is exosomes which are negative. On the right side, there's the positive analysis, and it's always distributed about male and female, that we don't have to look in detail, but we see in exosomes, we find a lot of spike proteins. We distinguished a little bit with vaccinated and people which are vaccinated and infected, but just when we compare that we have in exosomes, we really find spike protein. Again, this is from this year, and there's a lot of patients which are already treated with different strategies, including plasmapheresis, inospherese, and hyperthermia. The next slide, please. This is now the quantitative distribution of spike proteins in peripheral blood mononuclear cells and immune cells in monocytes. We didn't distinguish between the non-classical monocytes like the paper was shown before, but we just look at all immune cells, and we have seen, okay, negative, and on the right side again, positive. But again, you find the spike proteins in the immune cells. And now is the question how to treat them. There are some strategies from different clinics and groups that we have different strategies independence of the distribution of the spike proteins. But now, as mentioned in the talk before, is spike protein alone is not sufficient to show the serious problem of the long COVID post-vac or the combination. And therefore, we are thinking, what can we add? Which diagnostic can we add? The next slide, please. And some additional laboratory parameters for long COVID in general are some parameters. It's sonolin, CD14, lipopolysaccharide binding protein, myeloperoxidase, and properdin. And this is from the literature and also from former studies with infectious diseases, which I have done by myself. We see on the next slide a short summary why this parameters are relevant. First, we look at sonolin. Sonolin is a regulator of intestinal permeability, the tight junctions, and it's a marker for leaky gut. So you remember that the corona can also stay in the gut, or some pro-inflammatory cytokines are coming from the gut into the body. We have the lipopolysaccharide binding protein. This one binds lipopolysaccharide, and it indicates microbial translocation, like endotoxinemia. In your gut, you have a lot of bacteria, and which are a little bit destroyed, and the membrane of the bacteria is lipopolysaccharide, and lipopolysaccharide is an indicator for highly pro-inflammatory cytokine release. So the LBP is an early indicator of LPS exposure. Then we have the soluble CD14. This is a co-receptor for lipopolysaccharide, soluble in serum via a toll-like receptor 4. That toll-like receptors are receptors in our immune cells which recognize foreign proteins like lipopolysaccharide and other DNA, RNA, which is foreign or which is coming from viruses and from bacteria. So the soluble CD14 is a reference to cellular activation by microorganisms and by viruses. The next type is the myeloperoxidase. It's an enzyme for neutrophil granulocytes, and neutrophil granulocytes are the first defense line against also SARS-CoV-2, but also other microorganisms, and it's released during inflammation and oxidative stress. So it's a marker for neutrophil activity, also a marker for defense against microorganisms. And at last, we have also properdin. Properdin is a stabilizer of the complement convertase complex in the alternative complement pathway. It's a very, very old pathway, which is a marker of a complement activation, which is a very old defense system against microorganisms. So the next slide, please. And then we were thinking, is this sufficient to look at the sonolin soluble CD14, which is really important, but we looked at additional laboratory parameters for long COVID, and then we get to the danger-associated molecular patterns, or called DAMs. In the 1980, 1990, and later, we did a lot of manuscripts and research on this danger-associated molecular patterns, and I want to introduce now some of these parameters in the next slide. So what are DAMs? DAMs are, one is histone. Histone is released during netosis, also it's a cytotoxic molecule. Netosis, what is netosis? Netosis is again the activation of neutrophils, also granulocytes, which are the first defense line. Then we have interleukin-1 alpha. It's a nuclear alarmin. It's a very early activation parameter for pro-inflammatory cytokines. We have also called HMGB1 or 1. It's a chromatin protein. It's highly pro-inflammatory. We have the heat shock protein 70. This is a stress indicator, also a very old indicator for a stress response against a lot of stressors. We have the S1 proteins. It's also again from neutrophil granules, also a marker in autoimmunity. Again, you see the first defense line against microorganisms are the neutrophils, and they play a very important role, which we now recognize. We have uric acid. It's a crystalline form. The crystalline form is also a DAMP. So it's from from cell decay. It's from destroying a cell type. Then now perhaps you are a little bit thinking, why ATP? The next one is adenosine triphosphate. Normally we need adenosine triphosphate for energy, but it is normally intracellular, but if it is released extracellular, it acts as a signal. It's an inflammasome activating, so it leads as a signal for stressing. So extracellular ATP is not a good sign. And then we have again a little bit from the mitochondrial. And now you remember the mitochondria are from the origin of mitochondria are microorganisms, are rickettsian. And the mitochondrial DNA, also mitochondria still have a little bit own DNA, also information for their proteins and so on. And this DNA, or the mitochondrial DNA, has characteristics of microorganisms. And there are also some proteins inside the mitochondria which also have characteristics of microorganisms. Now our immune systems really has a lot of receptors which recognize microbial proteins, nucleic acids, and so on. So if mitochondrial DNA is released from mitochondria, they activate receptors, and our immune system says there is danger, 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 there are different microorganisms. So the mitochondrial DNA is a very important danger-associated molecular pattern and activates a lot of receptors and induces a pro-inflammatory response. The next slide, please. And now you will ask why I'm focusing on these DAMs, also on danger-associated molecular patterns. They are activating the immune system, the innate immune system especially. There's a stimulation of inflammatory responses, especially interleukin-1, interleukin-6, TNF-alpha. It is again a recruitment of immune cells, neutrophils, monocytes, again from the innate immunity. And they are a promotion of autoimmunity during chronic exposure. And we have an inflammasome activation. So if they are really DAMs additionally to spike proteins, or if spike proteins are inducing the release of DAMs, also danger-associated molecular patterns, then we have additional problems like autoimmunity and pro-inflammatory cytokines. The next slide, please. Yes, and now we come to a further part, which further laboratory parameters are also good for long COVID. And there are the cytokines. We already mentioned the cytokines because they are released from the activation or the release of danger-associated molecular patterns. But let us look a little bit at the cytokines, which are relevant for long COVID. The next slide, please. We have looked at a multiplex cytokine panel because one cytokine is not sufficient to look whether there's a problem in long COVID. We have one panel for pro-inflammatory cytokines. This is interleukin-1 alpha, TNF alpha, IL-6. You also know from other microbial infections. But we have also looked how much or how strong is the anti-inflammatory cytokine release, like interleukin-10. Then we also look at the chemokines. What are chemokines? Chemokines are cytokines which attract other immune cells, especially the immune cells of the innate immunity, especially neutrophils and macrophages, which also can release again some enzymes or cytokines. And this chemokines which are relevant is interleukin-8, which especially attracts neutrophils. Then it's RANTES, which especially attracts macrophages. You remember that macrophages play an important role in spike protein exposure. Then we have MIP-1 alpha and MIP-1 beta, which are also attract macrophages. Additionally, we have some cytokines which have a thromboinflammatory profile, which we don't like. You already heard the last talk about the microclots, and thrombocytes add to the microclots. It's the CD40 ligand. Then we have also endothelial activating cytokines, which also activate the endothel and also attribute to the microclot formation. It's vascular endothelial growth factor, also VEGF, and the monocyte chemotaxis factor is MCP1, which is also transforming neuroinflammation. Then we have also especially the trained immunity, the non-classical macrophages you already have heard. It's GM-CSF. And we have some cytokines which are especially for T cell activation. It's interleukin-2, interleukin-4, interleukin-13, and interferon gamma. So dependent on the cytokine profile, you might have different problems or signs or signs of inflammation, of problems, and you have to treat them different therapeutically. So then we go to the next slide. And now we are working on this senescent cells. I always call them zombie cells, again in German, sorry. What are senescent cells? That are cells which are walking a line between life and death. They are not death and they're not alive, but they're producing a lot of pro-inflammatory cytokines. And we have different scientists have seen that especially the spike protein infects monocytes, which then go into this senescence profile. So we now focus to look how many cells of the immune systems have this characteristic of zombie cells or of senescence, because that is a very important part to destroy the senescent cells. Also, that the immune cells are again fit for defending against the microorganism, because these senescent cells are no longer able to defend against this microorganism. Moreover, they are they are focusing on neighboring cells and say to them, please behave like senescent cells. So we have to destroy the senescent cells. The next slide, please. Yes, and now why are the senescent cells have different roles? First, the spike proteins, and different scientists have shown that the spike proteins induce a senescence in different tissues. And normally, the senescent cells don't longer have the characteristic of this tissue, and they do pro-inflammatory cytokine release. Normally, our immune system should eliminate these senescent cells from everywhere, from the tissues, from the muscles, from the brain, from the heart, from everywhere. Through different mechanisms, through the T cells, through the natural killer cells, through the complement activation, to B cells, to the macrophages, but also to the neutrophil granulocytes of the innate immunity. But if these cells are senescent, like the macrophages we have seen, or the neutrophils, then they can no longer remove senescent cells of the tissues. And so we have double problems. Yeah, we have problems that the senescent cells are not removed, also from the brain or from the tissues, and we have a problem in the immune system. The next slide, please. And this is again the molecular mechanism of immunosenescence. It's a summary. So we have the hallmark immunosenescence. That means immunosenescence is the senescence of the immune system. As the immune system should remove senescent cells everywhere in the body, but if it's by itself is immunosenescence, it can't remove the senescent cells from the body, also not from the brain, not from the heart muscles, not from everywhere. But what are the hallmarks of this immunosenescence? If we look at the T cell population, then the naive T cells are diminished. The memory T cells are increased. The effector T cells, which are killing cells, are also decreased. And we have no longer an antigen recognition. So we have an impaired immune response from T cells, B cells, and CAR cells and macrophages. And on the same time, we have a thymic involution. You see it on the left lower side of this slide. And if you don't have, and if you have a problem with your thymic, then you have no longer a T cell output. Again, also a problem. Then on the right side of this slide, you see the inflammaging. So that means that these immune cells, which are senescent, release a lot of cytokines. It's called senescence-associated proteins, senescence proteins. So it is IL-6, IL-8, IL-18, IL-26, interferon gamma, TNF-alpha. And additionally, your immune system can't anymore combat any infection. You see it on the right side. It's on the metabolic changes. So it's the mitochondria are involved. So they can't anymore produce ATP. You have no more mitochondrial biogenesis. So the mitochondria are not reproducing. And you have a lot of reactive oxygen species, which destroy your membranes and do a lot of oxidative stress in your body. So next slide, please. Yeah, that is a summary of the immunosenescence. It is covering the T lymphocytes, the macrophages, B lymphocytes, neutrophils, mast cells for mast cell syndrome, and natural killer cells. Next slide, please. Yeah, then we are at the summary. So we started with the detection or analysis or quantitative analysis of spike proteins in the serum or plasma, in exosomes, and in the immune cells. And we have shown, or others have also shown, that the spike protein has a central role, but we also have to focus additionally on the central role of the immune system. We have to look at the senescent cell of the immune systems, or have we to introduce senolytic compounds which destroy the senescent cells. And we have also looked at the central role of the danger-associated molecular patterns, which increase again all the pro-inflammatory cytokine. And if we do everything of these parameters, perhaps then we can better calculate which of the therapies are the best to choose at which patient. So I thank you very much for listening. And that is, that was my summary and the end of a very short summary of our analysis at the moment.
Excellent. Thank you very much, Bridget. So this is something that is close to my heart with regards to this dysregulation of the immune system. And I think that it is grossly underestimated, because if you're not doing these investigations, these cytokine testing, people just don't know until they get sick.
Yes, you have to look at different parts. You can, for example, start to look whether the cytokine profile is different. You can look whether do you have sign of neuroinflammation. So would be an easy step to look whether there are some problems. So the cytokine profile is an easy way to just look: are there problems, or do you have a pro-inflammatory profile?
I want you to challenge a statement that I say very often to patients, is that the people who are most prone for this kind of response very often have an element of an inflammatory process already in place. And it's like the spike protein spraying petrol on the embers of inflammation. They just significantly augment any inflammatory process that's already there. What do you think about that?
I think I didn't get it totally. Sorry.
Yeah, so I was just saying that the spike protein seems to make inflammation worse in people who already have some degree of inflammation.
Yes, that's right. And that we see. So it depends on which background the spike protein is coming, or is coming into the organism. If the spike protein, if the organism is mainly healthy or not pro-inflammatory, then might be that the immune system can diminish the inflammation and limit the problem. But if you already have a pro-inflammatory status and your immune system is already augmented, and then you come additionally a problem which increases the senescent cells, which damage the mitochondria, so that the remaining immune system cells are not operating well, then you have really a big problem.
Yes. And I was just reflecting on something as you were talking. You have touched on something that very few in the scientific community will do. You have clearly delineated the fact that some people have post-COVID issues from infection, some people have it from vaccination, and a lot of people have a combination of both.
Yeah. Right.
Have you got a lot of pushback from saying that from the scientific community?
No, also at the moment we get samples from people which are ill, and we have some which really didn't have vaccination, which they say they didn't are vaccinated, but they have big problems. Therefore, I think it's important that we communicate with the centers which send us the samples and look what is the problem with the patients. when did they have the infection? Did they have a chronic infection before? But what we can see is that a lot of people which were very, did a lot of sports, where they tell they are very active and highly active in sports, that they have very big problems. Yeah. So we know that a lot of people which are doing a lot of sports are not the healthiest people, because they damage the mitochondria. That may be perhaps they have a lot of mitochondria, so it's compensated, but the individual mitochondria is not in good health. But again, your question is, we have to communicate better with the centers so to calculate it. But the IOS clinic, I think they get our data and they can look which therapy is the best one.
When we think of the zombie immune cells,
Yeah.
and that is for me one of the biggest concerns, because these immune cells that don't die, and they can already live a lifetime, but they're not functional. They're producing inflammatory processes that are making people sick.
Yeah.
That to me seems like the greatest risk out of all of the things that you have mentioned.
Yes, I think I agree with you. And that was also mentioned before by Patterson. We had shown that also the monocytes, macrophages, are senescent, also zombie cells, but we also see that are T cells which are senescent. Yes, I agree totally with you. And therefore we focus now on detecting them or characterizing them and do the quantitative analysis. And I think also that for example, Molecusan, we know that Molecusan is supporting this meeting, but independent of that, Molecusan is focusing of the senescent cells with Senolytica. So you have to look perhaps also on Senolytica and Xenomorphics. Xenomorphics are substances which modulate a little bit the senescent cells. They can't destroy them, but they can modulate the release of the pro-inflammatory cytokines. Yeah, but yeah.
Excellent. Yeah. So I think that when I consider how many people have chronic inflammatory issues at the moment, is it a reasonable or honest position to let people think they are going to get back to normal, or is it that we are in the realms of managing a chronic long-term autoimmune kind of picture where we can keep it in check but they are never quite back to normal? What are your thoughts on that?
My thoughts are that we are able to get them healthy again, not in a chronic state. But it is not done within a week or something. We have to combine different strategies, but for example, because the mitochondria are also involved in this process, and mitochondria are able to replicate. They can be renewed, or that's a mitochondrial biogenesis. So we also see by some people that they can really regenerate, but it takes time, unfortunately. But it's the hope that it's not an ongoing chronic disease, but that they are resolving.
Excellent. Wonderful. So listen, what we're going to do now, Bridget, is that we're going to hear again a quick word from our sponsor. Then we're going to bring back Markus, and we're then going to have an open discussion reviewing some of the topics that have been presented. And this is where the audience members, if you have some relevant scientific points or questions, please put them in the chat. I will do my best to try and address those questions just in another few minutes. So let's hear a final word from our sponsor.
And So when COVID started on day one, that is January 2020, I think around the 18th, we dropped everything. And ever since that day, we've been working 7 days a week, practically around the clock on finding solutions. Everybody on that slide you see there, to some degree, are working almost either on a weekly or daily basis, or even in direct collaborations, in research collaborations, in publications, in lab research. And so, each one there you can see has significantly contributed either to treatment or to development or understanding the disease and other discoveries. And so it's a great honor for me to be part of that and to be able to mediate between all these groups. I'm kind of like the coordinating a little bit between all these domain experts.
Thank you, everyone. Just an important point at the end, it mentioned coming soon to the UK. We will be happy to know that Molecusan is now available in the UK in the past week. For those who are interested, you can look up their website. I think that I do want to make a point here, because although we are being supported here by Molecusan, I think that everyone who has interacted with Joachim Gerlach, who has been one of the critical founders and instigators of this, have realized that this is someone who is extremely passionate about the science and finding ways to help patients. And I think, I'll say something here. He is an engineer. He's not even a medic. And he has done more to support the battle for finding therapy and treatments for people with chronic illness than anyone else I can think of in the medical community. It is quite remarkable what he has done.
Yeah, and the funny thing is, Philip, do you know anyone that you can call 2 o'clock, 4 o'clock in the morning, and they will pick up and they'll just not even say hello, they'll just start sharing their latest findings? I cannot even tell you the countless nights that Joachim and me between 2 and 4 o'clock were on the phone and discussing things. And he's driven. I would say it's a healthy obsession, basically, that he has, right? Yeah.
Yes. So but as we come back to the issues that we've said in terms of the challenges, one of the points that I think I struggle to get across to patients, and my thinking and my approach and the research that I've been doing, I say that technically, and I follow this here, I just said this recently to someone, and I want you to challenge this statement. I said that similar to measles, where measles enters through the respiratory tract, but the primary pathology is on the skin with the rash, and probably when it affects the brain, and it exits through the respiratory tract. So you could almost call measles a respiratory disease, but it isn't a true reflection. In the same way, SARS-CoV-2, even though it enters via the respiratory tract, the pathology is in the bloodstream and in the gut especially. It's like a completely different pathology from where it enters. And most people tend to think of it as a respiratory virus, not necessarily as a vascular damaging, immune affecting virus that causes so much pathology. Any thoughts?
Well, I think it's pretty hard to challenge that one, because it's spot on, actually, Philip. This is exactly what we're seeing. long COVID at the end of the day is vasculitis, endothelitis, right? Combined with immune deficiency, T cell response, etc. So I think your analysis was perfect. Now, the only thing that I might add is the subsets. There is different subsets: hypercoagulation, microclotting, immune deficiency, and then you have the blend of those two, and then there's several other subsets, and they can really be varying because it really depends on the reactivations that we see in the back, right? Now, there's this one little part in the S1 spike protein that's capable of what we call staging, right? It can reactivate basically dormant bacterial problems, dormant, even genetic problems, and dormant post-viral problems. So that also contributes. Lately, we've been seeing people coming in and they saw that they have Lyme disease, right? Borreliosis. Turned out they did have very high titers when we tested it in Armin lab. But it also turned out when we tested the same samples with Bridget that it was driven by spike protein. And interesting enough, you can treat that, but not with a monotreatment. Apheresis alone doesn't cut it. Hypothermia alone doesn't cut it. You need to combine those. And if Lyme is involved, in addition to the molecular that we use in post-vac and long COVID, we use certain biofilm busters. So not easy, but doable.
Just picking on that point there, Bridget, when what he said there with regards to Lyme disease ovation, how does do you see any patterns with that in the lab necessarily?
Can you please repeat? I didn't get the middle. You disappeared.
Yeah, so the question was that Markus was mentioning that they are seeing certain reactivations of things like Lyme disease and so on. And my extrapolation to that was, say, for instance, Epstein-Barr virus. When you have this immune senescence, as you described, and you have reactivation of these hidden viruses, do you see any patterns in the lab, or do they look the same as other presentations?
Yes, perhaps some words to Markus. Yes, and to you, the SARS-CoV-2 is entering through the respiratory system, but it's a systemic infection. We didn't know it at the beginning, but now it's clear. And yes, there's a lot of reactivation of viruses, Epstein-Barr virus, cytomegalovirus, and others. Borreliosis or Lyme disease can be or augmented. This is one reason is the problem with the immune system, yes. The senescent immune system cells, and we see this also. We are now working on an analysis to really see the single reactivation steps of the viruses, yeah, to get it more clearer than it is done before, also up to now. But yes, it is one reason of the immune system. If it is not functioning, then the viruses are reactivating. Yeah.
Somebody said something here that I captured that I thought was so true, and we need so much more of it, which is that this is how scientists and doctors should work together, interdisciplinary sharing knowledge, new findings, so that the big picture can be detected by adding the pieces of every finding together and discussing it. Why does it feel as though it's only a small group of interdisciplinary people in different subsets across the world?
Yeah, I'm also not just in Switzerland, and here it's a different topic, but here also some people which are working on Corona, SARS-CoV-2, and yes, we should work better together. That's right. Because everybody is occupied by his own work, and so yeah, I myself have also to better cooperate with others, the others as well. So it's really time to have a better cooperation. We are a group, or not a small group, of scientists. But you are right. We should be much more scientists to work together, because it's a infectious disease problem also from SARS-CoV-2.
Your thoughts on that, Markus? Yes, go ahead.
Sorry for crossing you. I think we.
No, I'm saying your thoughts on it. Go ahead. Yes.
I think we need better tools as well, and that's what my work this year is about. So every year I do different things, right? So the first year was collecting the treatment portfolio. Second year, collecting diagnostic portfolio. Third year, trying to optimize the algorithms. This year, it's all about getting the right tools to communicate together. So I'm trying to get a platform where clinicians and scientists can work together on an open medicine database. Because as Bridget quite rightly said, we keep sending her samples, but we don't send her every presentation with it. So she gets a sample, Mr. John Doe. She doesn't know what illness that person has. She doesn't know in which stage, for how long. We have all of that data. It would be so great if she could just look it up, right? And the other way around. So if she has more data than is in the reports, like she said, by the way, I had an afternoon where I could play around. This is 6 other tests that I just did randomly. Look at this here, right? Just upload it. So what we will need is this open medicine database where we automatize digitally sending, basically, hey, there's a sample on your way. Did it arrive? Yes. Confirming it arrived. Those are the lab tests. That are the results. That's what's been tested. And also, this is all the presentations. This is the weekly surveys of the patients. And this is the biotracking results of the patient. Because there is one thing that I've been really worried about. If you look at people with chronic illness, our self-assessment is so incredibly off. Philip, you have no idea. I came home after treatment, and I was literally reawakened from the dead. And then I just told everybody I'm healthy. And my missus and my doctor said, Markus, you're maximum 50%. You just forgot what it feels like to be healthy. And they were right. I needed another 4 months, right? And then it goes also the other way around. Treatment number 3, help apheresis. My mother had a gastritis, just pure coincidence. And she said, Markus, we need to stop these treatments. They make me so much worse. I said, Mom, we've been biotracking you. Your heart rate when you go up the stairs is now back to normal. This, that, here, there. And she said, oh, really? I said, really? She said, well, then let's continue. After treatment number 4, she said, I'm good. I'm going to fly home on my own, right? So it can go up or down, that self-assessment. So we need next of kin. We need surveys, but we also need to biotrack them. And it's quite interesting. We've also seen that this can be very much influenced with 2 other treatments, actually, how people assess themselves. One of them is ketamine treatment, intramuscular. And the other one, if we combine that with RTMS. And we're using a protocol by Dr. George Michaelides, who has adapted the Harvard protocols. Ketamine calms down the vagus nerve, the autonomous nerve system, indirectly, of course. And basically, people respond so much better to treatments because they are actually out of that misery. Because don't forget, most of our patient population is anxiety-driven, has manic thought loops, has depression. It's incredibly hard to recover in such a state. So if you take off a bit of their burden, repetitive transcranial magnet stimulation, ketamine, then you can see that their responding speed is increased. And that's anecdotal at the moment, but we're collecting data, and that's where that open medicine database comes in. Because what I learned today, tomorrow you, on your island, just use it for free. And all we're going to say is, great work, Philip, well done. And the other way around. That's how open medicine goes. If we share knowledge...
Yeah, there was something you said there that struck me. I'd be interested in Bridget's thought on this, is that I was recently looking at an autopsy paper. It wasn't focused on specifically COVID. It was COVID in someone who died about 12 weeks after they were infected with progressive neurological decline. And one of the things that stood out to me was this issue of vagal nerve inflammation. It does seem that a lot of people, a lot of the symptoms that we are seeing in relation to long COVID is around the fact that their parasympathetic system is being damaged and it can't balance out that autonomic or automatic nervous system. Do you see any patterns, Bridget, that would substantiate this strange neurological pattern that seems to be coming, especially from Omicron infections?
I can't say it exactly, but the mitochondria are the receptors or communicating also with neurotransmitters, and that we have to look more, I think. But it's one idea that the mitochondria are at central points, that the sympathicus parasympathicus is not functioning anymore.
Yeah, so these are big issues that that need complex resolution. And as I thought of all the DAMPs, the damage associated proteins, it is such a spectrum of investigations. You know, it's so hard to then pick patterns that are going to respond. You know, and I find that really, really difficult. That it's kind of like an infection. You can see a moderately raised CRP, but the person is very sick, you know, or somebody with a very high CRP and they're not so symptomatic. And so you have all these numbers, but how do you integrate them into a clear strategy to bring about benefit?
Also, I covered this DAMPs and other parameters from research with a lot of microorganisms and viruses. We did it. We focused years ago on also on EB Epstein-Barr virus, on respiratory syncytial virus, on influenza, on different para-influenza, on microorganisms with different pathogenicity factors, with super antigens, and so on. That was our topic. And so we focus on that. And sure, Corona or SARS-CoV-2 is a novel pathogen, but if we combine the results, I think we can get a picture of that. Yeah, we have just to remember what we have learned from all this is infectious diseases and with the pathophysiology. And I have seen now a lot of papers which I have done or results. I have them now in my room, and I will go through. We have all the data, but we have now again to think about that, yeah, to get the right way or the right therapy. Yeah, I think it's not really new. Yeah, we all know it from some others. Super antigens. Yeah, there are a lot of things. We also publish a lot with super antigens, and I think they are also here relevant.
So, Richard, I think you're right. We know the little pieces of the puzzle, each one of them quite well. There is new things, but not that many. But we've been using AI since about 10 months now, because we put all of those results in. We ask our AI, we train it specifically. So we have different instances of AI so that they don't start hallucinating, which is very common in very highly specific data pools. So when we train our AI, what we do is Dr. Imbar has been really good at this. So we always double check, because sometimes the results they come up with, they just don't make sense, right? But it gets better and better and better every week and every month. So what we do is every test that we get back from every laboratory, we upload it into the AI, and then we start prompting it in different levels and layers. Okay. And then actually the results that it comes out with, they're actually quite good. Then all we need to do is control it with a doctor, and then see, okay, let's see what the interventions are. And that's been helping quite a lot. I mean, we've lately had a few cases where we had reactivated Lyme with COVID, Bell scale 10 to 20, fully resolved within 6 weeks. And that's all been AI driven. And that's all been driven by results from your lab, from other labs. So we're getting there. And I would say I now agree that we can help a large number of people. However, there's this one group that's killing my sleep every day. And that's the group with MCS, multi-chemical sensitivity, mast cell activation, and severe chronic fatigue. We can't even touch them. Anything makes them worse. No matter what we do, any intervention is having a negative impact. Now, we have somehow, and that's a question to you, Philip, because you've seen so many patients as well. We've somehow seen that if we go down with plasma rates, if we go down with moderate temperatures and hypothermia, super low dose medication, and we really take weeks and weeks and weeks, we can slowly move the needle. Have you observed patients like that no matter what you do, they will have a negative response?
Yeah, I think that sometimes, and so I tend to have a relatively simplistic thinking around COVID and long COVID. And it was based on the fact that prior to the pandemic, I was already noticing a pattern. And the pattern was that many people who had chronic illness patterns, symptoms, the vast majority of them had gut-related associated symptoms. So I had noticed this prior to the pandemic. And when the pandemic hit, what I saw were the same kinds of people had the worst outcomes with regards to long COVID type picture. So my rule is pretty simple in my mind, and it's difficult for people to understand because it seems too simple to be practical, is that first make sure that there is no intestinal activation, because especially with COVID, I really think that COVID is primarily a gut disease with vascular vascular patterns. So if I had to pick where in the body is the primary pathophysiology, I would go for the intestine. For Omicron, more specifically, the terminal ileum of the small intestine, where you have the highest level of heparan sulfate. Because if you already have an inflammatory process and you then have the kind of immune dysregulation that Brigitte was pointing out, where you have decrease in the T cells, especially the regulatory cells, you have the zombie monocytes in that vicinity continually releasing inflammatory processes. You cannot fix that if you haven't fixed those issues. And so when I see those people, I know that there is a nidus somewhere that if you don't identify it and if you don't address it, you can't solve it. And to answer your question specifically with regards to MECFS, this is prior to the pandemic, the one region that seems to be really, really important is the epipharynx. They found this in Japan beforehand, that actually treating the epipharyngeal region right at the back of the throat with zinc chloride ameliorated symptoms in 2/3 of the patients. So it seems that when you look at therapies, if people have primary inflammation in that region, that is one of the toughest regions to be able to settle down. And that's where you will find that almost nothing you do quite works.
So would you agree if we would say it's not only what we just described, but it's a systemic illness? Because literally there's no area in the body where this virus cannot do harm?
Yeah, I think that when we looked at, there was a paper that showed all of the associated conditions with long COVID symptoms. And one of them that stood out to me was endometriosis, and the other one was benign prostatic hypertrophy. And at that point, I realized that if any location in your body is inflamed,
But
this
then sorry.
Go ahead, Brigitte.
But then it would be useful, additional to the simple spike analysis and the microclots, to look at some specific cytokines which go to the endothelial activation, and to look at some danger-associated molecular patterns, especially for the gut-related, like soluble CD14 and lipopolysaccharide binding protein.
Well, I think that what I've learned now is that you use the tests to support the history, meaning that you can tend to know where is affected if you really do a very detailed analysis of the history. So if somebody had absolutely no gut-related symptoms, and sometimes that can be hard to tease out, you know that it's unlikely that's going to be the nidus. You then will hear that they have primarily upper airway symptoms, lots of history of hay fever, that went back lots of time. Now, then your issue is probably more a sinus-related inflammation. How in the world do we get that settled? Do you see what I mean? Is that it's if you can't deal with the embers, it's then very difficult to completely resolve the inflammatory process. That's my thought on it.
And Philip, I think that's why most of the treatments that are very broadband, like whole body fever range hypothermia, right? That works. I mean, my wife had she's a former pro swimmer. She had an ear throat infection from swimming, open ocean. She did a hypothermia, resolved. I had a chronic bronchitis, 8 weeks, not very clever in a clinic full with chronically ill people that are there because of infectious diseases if you cough all the time, right? So I got treated with hypothermia as well. Within 8 days, I could feel how it completely resolved the chronic bronchitis. So this hypothermia seems to be, and we've published some papers, you'll find them on our website, seems to be a really good way of getting to literally every area because you can heat up the whole body. Now, here's an interesting observation. Most people like to leave their head outside of the soft chamber in hypothermia and will blow on their face with a little fan, put a wet tissue or ice cubes, and so on. However, some symptoms that are related to the sinuses, etc., you need to have the head inside of the hot chamber. Otherwise, it will just not work, right? Yeah.
You know, so that as you mentioned, the MECFS cohort, which has always been a very difficult cohort. Bridget, when you see that cohort in the lab, is there any difference in terms of the lab numbers that come up? Do they look different from others?
And so normally MECFS people have a surprisingly better mitochondria. Yeah.
So primarily mitochondria.
Yeah. Yes, that is a difference. And you can see at the mitochondrial performance and specific parts of the mitochondrial function whether there are more problems. And we can also look whether at basal state, at an activated state, whether the cells are able to use fatty acids or glucose or something, amino acids. There are the differences.
And so when you look at their blood parameters, which readings tend to come up the highest in that cohort?
Yes, at the MHCSF?
Yes.
That the mitochondrial dysfunction is different from the others. So
Wow.
the individual parameters.
So you see, Markus, because what I think is happening for some people is that they may have been mildly on the spectrum of MECFS, where they probably say had only very mild symptoms, nothing major. Then COVID comes and it pushes it over the edge. So what you are dealing with is not purely long COVID, it's technically MECFS exacerbated by COVID.
Yes,
That
and here
is
comes the bad thing. Long
Yeah.
COVID, certain subsets, if not treated in time, will eventually turn into MECFS.
That's a good point. Yes, that is because based on what Bridget is saying, if you leave the inflammation long enough and it continues to damage mitochondria, then yes, they become functionally MECFS with mitochondrial disease as the primary driver.
Yes.
This
Yeah,
is
but let's come a little bit to those points where we get a lot of pushback from scientists, other scientists, and doctors, and where they criticize us, because I always like to put a little bit of light on that too. And we've mentioned this in our pre-talk that you're also very interested in this. So I can give you 2 examples where we get like a little bit of pushback. First of all, there is people who walk around and they have elevated microclots and they have elevated spike protein, but they're completely functional. They might have minor symptoms in some cases, but there is that 1 or 2 out of 100 that are symptom-free, even though they have elevated microclots and spike protein. And I gave this some thought. And I think there is people that genetically tolerate microclots better. And I think it's what Jordan Vaughan found out. If we can use all of these fibrinolytic pathways, I think there's 4 of them, then microclots tend to not be such a huge problem, even though they're built with amyloid protein, because somehow the body can still keep up with them. So there is different cohorts of people who respond differently to microclots, for sure. The same seems to go for spike protein. And that's actually quite inevitable as well, because for, let's say, just a guess, 80% of the world's population, spike protein is not a huge problem at the moment. Now, Brigitte quite rightly says it's never a good idea to leave spike protein into a human body for too long. But you don't want to be in that 20%, like I was and other long COVID patients were, where it makes you bedbound, right? So clearly people respond differently to microclots, to spike protein. And here comes in all of the other testing that Brigitte is just working on, and Joachim. I think it's not just those 2 markers. And I think the third category is GPCR autoantibodies, agonistic receptor autoantibodies. But a lot of what Brigitte showed today, and the data is so new that I couldn't possibly tell you where that's going to go, right? This is going to be so exciting, because this is things that we're now going to send to Brigitte. And if we speak in 6 months, I can tell you, hell yeah, 50% of what Brigitte said on that conference, she was right. The other 60%, 50%, yeah, we didn't find anything, right? And that's the exciting part. And now let me just bring you 1 year forward, when we're going to have our whole open medicine database that's AI driven. In 1 year, you and me, we don't need to hypothesize anymore. So we can just go in and prompt in the AI database and say, hey, Philip and me just had a discussion about a cohort of patients that are a blend of A, B, C, D, F, G, and this and here and there with this and this indications and symptoms. What did you find in your database? What were the patient cohorts, male, female, spike protein from COVID, from the vaccination, and which treatments did work? And every year, more clinics are going to contribute to that database. And every year we're going to talk, we're going to find a lot of new things just from that. Some might not be that accurate. I'm not a fan of AI in every sense. It still keeps apologizing to our doctors 20 times a week when they catch it cheating, right? So there is flaws. Let's not think it's perfect. But it's going to be driven so much further every 6 to 12 months that every conference that we have every 6 to 12 months, the findings will be not linear, but progressive. That I'm pretty sure of.
There's one aspect of this that is very difficult to predict. And for those people who have seen patients in pain, you realize that there is a huge spectrum of responses. There are some people who would break their wrist and they barely notice. And they literally walk in with a broken wrist or broken ankle walking on it. And then there's another cohort of people who, even with the slightest strain, can't walk on their leg. So one of the interesting pieces of research was shown that people exposed to interferon in treatment of hepatitis C, there was a cohort that had a lot of symptoms exposed to interferon. Okay? Mm-hmm. What I am suspecting is happening is that the cohort who has the most sensitivity to the inflammatory cytokines are the ones with the most symptoms. So it's not necessarily that they have the most abnormalities, but that their immune system or their person is sensitive to even the slightest change in their inflammatory markers. How do we then bring that into, because then the lab readings won't fit. The lab readings may show that it's not so high, but the person feels very sick. And that now makes it really complex, because at the end of the day, all of their labs may be improving, but the person doesn't feel better.
Yes, but there's two concepts that we can inject there. One is called DTR, diagnose, treat, repeat. And the other one is called morphing patterns that AI can slowly take care of, right? Because what you're speaking about is basically cohorts of people that are at the first looking exactly the same because all of their markers are the same, but their outcome is different because there is one marker that we didn't take into consideration, right? So I think if we combine that with data points of surveys of them, next of kin, and the biotrackers, we can identify that. I think that should be possible.
Yes. I'd like to ask Bridget a question as we're coming here towards the end. Now, a lot of people don't have access to the high-powered investigations that you say are doing in your lab. And even if their doctors probably wouldn't ask for it. If you were going to give simple advice to someone who was going to see their doctor and they wanted to know if they were having this kind of inflammatory process as a driver for their symptoms, are there any simple tests like, say, the D-dimer, the ferritin, the CRP? Are there any simple tests that they could ask their doctor that could give clues?
I think CRP is not the right parameter. The D-dimer, sure, that could be one hint. Yeah, it depends whether we can look just on whether spike proteins are inside or the cytokine. No, perhaps we have one test. It is from the immune and you see whether your immune system can respond, and it is from, and here's my from organ transplantation. So sorry.
From organ transplants?
Yes, because you look whether you have to go out with immune suppression, and then you look for your interferon gamma response to different activators from the innate and from the adaptive immune system. And if you don't have a response, then you have to reduce the immune suppression. And then we see that we can look whether this is okay or not okay. Also then we see we have some which
That's
are...
a great idea, Richard.
What?
That's a great idea.
Yeah, no? It's yes, we tried it now several times with my students. We did something, and so they don't respond anymore, but they are not organ transplants, and I think that is perhaps a good test. It's simple.
So can you just delineate? Do you know what test she's talking about, Markus?
Yeah, so basically, yeah, I do, but I don't know which labs do them. So when you've received an organ from a donor, you need to define the level of immunosuppression so that the organ doesn't get rejected. And that is exactly the test.
Oh.
So, yeah. And I like the way of Richard's thinking. Very clever. If we can see that response, we can actually trace if, and you didn't get an organ, but it's the same test. If your immune system is suppressed already, or if it's still working. That's actually a clever approach.
Yeah, you're right. So that would form a baseline for where, and you could then use that as your measure to see the response to therapy. It's as a very broad measure to see the immune response. That is very interesting.
Can you do the test in your lab, Richard?
Yes. I introduced it, and now I did several comparison with your samples also. Yes, I can do it. It's very, very, very easy.
How do you call the test? Does it have a specific name in your lab?
Immune competence.
All right. Nice.
All right.
Well, I'm going to send you a few samples more just for the... Yeah, this is great. I have some really
this is the kind of thing that happens with the collaboration, because fundamentally what the struggle for many people is they don't know if they should go on to do big complex tests, and even if they did, who is going to interpret it for them and then implement a strategy depending on where they are in the world. But if there is a very simple test that can be easily interpreted wherever they are in the world, then suddenly that test becomes extremely valuable.
It's an EVDR, so it's really validated. You have exactly the values. You know whether your immune system is down, whether it's moderate, minimally moderate, or okay. And you only need 4 milliliter heparin blood, and it's very easy interpretation.
Very nice.
And so that reminds me again, then, Bridget, just thinking creatively, when we do hematology tests, basic hematology tests, where you're looking at not the INR, the APTT, one of them is, say, the clotting time. How valuable can those tests be? Because almost every lab in the world has the capability of doing it. Is there anything from those kinds of simple investigations that could be an indicator for, say, more microclotting?
Now, for more microclotting, could be additionally the vascular endothelial growth factor, so some or CD40 ligands, so 2 or 3 cytokines which you can put together.
But there's also one very simple other way, Philip. You could use a nail fold microscopy analysis. Very easy available, where the capillaries are parallelly aligned, and you can see if there's any issues in microcirculation.
Yes,
that's done actually in Germany, and it works very well. And another.
And what's that? So what's the machine? What do you say? What is easily accessible?
A nail fold microscope. It's basically just a very normal microscope, and you're looking at the nail fold.
Yeah.
The only place in the human body where the microcapillaries are aligned parallelly. Yeah. And you can then see any abnormalities. It is super easy. And in Germany it's done. We're going to get one soon as well, because it's just very cheap and accessible. And a second test that is also, you can get one, Philip, that they're not expensive. They're super easy to get. I'll send you a link to a German company that does them very well. You could even get one from China, because it's not very complicated, you know.
Dr. Wiechert at Bremen is doing some courses. It's very simple if he's able to do it.
Exactly. And the second market that just came into mind that we're already doing constantly. So we're using blood gas analysis, but we're analyzing the venous blood gas. And the one value that is not specific, but that is incredibly valuable for us, is actually the oxygen levels in venous blood. If you believe it or not, usually the level should be around 47 to 70%, right? But these tissues where the arterial blood gets into and comes back then are so oxygen starved in long COVID that we've seen people with, I think the lowest value was 17, 18, 19. That means you're clinically dead, actually, right? Because it's supposed to be 40 to 70. And what does that value tell us? It tells us when to stop with the interventions. If there's no other indications, that tells us when to stop with the apheresis. Very valuable, because there was cases in Germany where people just went on 10, 20 apheresis, basically unaffordable for everybody. And they could have been stopping at 7, 8. We just didn't have that marker back then, right? It's not specific. It's just, it doesn't tell you what's wrong. It just tells you there is still something wrong, right?
This is extremely, so this is why I think that these conferences are so valuable. As I said, I suspect that we are probably 2 to 3 years ahead of our time with this conversation. In 3 years' time, everybody will understand this, be knowing about this, and be thinking about this. But straight away, just some very simple takeaways as we come. Let me just capture them. The immune competence test, which is used in organ transplants, which Bridget's lab can do, and probably wherever you are in the world, if they do organ transplant, they'll be able to do it as well. Looking at nail fold microscopy, looking for the flow of blood, and critically, one of the ones that's used across the board in most hospitals is a venous blood gas, as you say. But it would have to be assuming that the patient is not very unwell at the time, and so you can't do it in a very sick patient. But if they are okay, and you see significantly low oxygen levels in the venous blood, that, as you said, could be a very strong indicator of ongoing tissue issues. So those are 3 very simple but powerful techniques that can be implemented if there are any clinicians who are listening.
Fully agree. Fully agree. And you can do the venous blood gas oxygen test even on a completely fatigued patient, because you only need very little. It's a few blood drops. You put them on a little disc. You put it in the machine. These machines are not super expensive. They're not super cheap either, the blood gas analyzers. The important thing is you have to do it right away. You can't really do it through a catheter. You really need to put a fresh needle. They're small, as you know, and get the venous blood out. And it's actually quite easy, but you need to do it in real time. You can't do it more than a minute of time shouldn't pass. So you do it in the clinical section. Yeah.
Excellent. So listen, what we're going to do now, I'll ask you to share your final thoughts. Bridget, I'll go with you first, and then Markus, and then we'll close out. So Bridget, based on everything you've heard and what you've shared as well, what are your final thoughts to the audience?
Yeah, first, thank you very much for listening. And I think we are on the right way. We will manage it. But we have to look at different parameters, not one, not spike protein is not sufficient alone. But I think I have shown you, or we have now worked out a profile which we can do.
Excellent. And Markus?
Well, my message of the day is, Bridget, you're the first woman in the world who changed my mind. I'm joking, of course, but I'm married since a long time. But I did not believe that we will ever be able to fix this completely, because I see people getting to 45, 65, 85, 95, and 100%. But the numbers don't look that great. We can treat 80%, but not everybody gets back to their old life. Many of them get a big part of their old life back. That I agree. But today, with that new panel of yours, I think we probably will be able to do it.
Excellent. Excellent. So again, thank you all for bringing this kind of cutting edge science in front of us all. We appreciate the insights, and I'm sure the audience who have been sitting with us for over 2.5 hours now have appreciated it as well. So I'll ask you guys to wait with me for the outro, and for everyone else, remember, we say thank you as well to our sponsor, Molecusan. If you are interested in their products, certainly available in the UK and the US as well. Have a great evening, and thank you all.